So polycythemia vera is a disease that we've learned quite a bit more about over this past 10-year period of time. At this year's American Society of Hematology meeting, we celebrate 10 years since the discovery of the JAK2 V617F. So individuals that have failed hydroxyurea, we have long struggled with what is an optimal second line of therapy for them, realizing many of them have unmet medical needs such as control of hematocrit, progressive splenomegaly, difficult symptoms. Ruxolitinib on December 4th, 2014, just before this American Society of Hematology meeting, was approved exactly for that purpose, on the basis of randomized phase 3 studies, the RESPONSE study that demonstrated significant benefits and activity in individuals who precisely had an inadequate response to hydroxyurea. In that randomized phase 3 study, of which I was fortunate to be involved, it was demonstrated that ruxolitinib versus best alternative therapy was superior in terms of control of hematocrit, in terms of splenomegaly, in terms of the ability of achieving a complete remission. So overall, very beneficial for these more difficult group of patients to treat with polycythemia vera. So several key updates we have at the American Society of Hematology regarding the RESPONSE study. The initial top-line data for that study we presented earlier this summer and is currently going to be published in a full manuscript form. At this meeting, on behalf of the co-investigators, I'm presenting the information regarding the quality of life and symptom burden, whereas we try to analyze the impact of ruxolitinib on PV-related symptoms. We see that there is significant superiority in the ruxolitinib-treated group versus those treated with best alternative therapy. Whether we look at individual symptoms such as itching, night sweats, day sweats, or symptoms related to the spleen, we see a benefit as individual symptoms as well as in aggregate. Other analysis that were done for this year's ASH were one asking the question about individuals after the crossover. So it was a randomized phase 3 at which patients were initially randomized to ruxolitinib or best alternative therapy. So we analyzed the experience. After 32 weeks, patients were able to cross over from the best alternative therapy arm to the ruxolitinib arm. And fortunately, we were able to see that individuals were able to achieve a high level of response, very consistent with those patients who had been initially treated with ruxolitinib. So they were able to overcome that delay in therapy by individuals going on the best alternative therapy arm.